So welcome everybody. My name is Eric Kruger, and I'm the Vice President of the AOPT Pain SIG. And today we have an international version of our Paincast, our quarterly sort of pain webinar, town hall, where we talk about interesting and niche topics related to pain and physical or physiotherapy. Today we are joined by two guests, Maxi Miciak and Giacomo Rossettini. I think I got the thumbs up on pronouncing those names correctly, so thank you. And the topic today is going to be on the therapeutic relationship. This is something that kind of probably changed this whole area, changed my direction personally as a physical therapist. So when I saw the recent commentary viewpoint article in JSPT by these two academics, I wanted to bring them on and delve more into kind of the therapeutic relationship. So I'm going to turn it over to them to allow them to introduce themselves and talk about where they're at. And then I think we're going to do a brief overview of the therapeutic relationship, and then we'll get into discussions and questions and answers, and we'll go from there.
All right, so maybe I'll dive in. Hi, yeah. I'm Maxi. I'm in the box up here. I'm Maxi Miciak. I'm a research associate and adjunct associate professor in the Faculty of Rehabilitation Medicine at the University of Alberta in Edmonton, Canada. And my research program is around therapeutic relationship and person-focused care. And I also do impact assessment, research impact assessments. And so I have some different hats that I wear. Yeah, and that's me coming to you from Edmonton. Giacomo.
Hi at all, my name is Giacomo Rossettini. I'm an Italian physical therapist. I'm specialized in musculoskeletal care. And actually, I'm working for a lot of my time as a clinician, and for an half of my time as a lecturer and a researcher at the University of Verona in Italy. So one of my line of research is about the placebo-nocebo effects and the use of the context around the therapy as a mediators of the therapeutic outcome. So we will have fun together with Maxi discussing about the interconnection between therapeutic relationship and also placebo-nocebo.
Yeah, and I think talking about just relationship, just because we were mentioning it earlier, Eric, before people came on, my relationship with Jack, our relationship, started with just a casual DM, a Twitter DM that I sent to Giacomo because we follow one another. And I knew I was on another podcast. I knew I was going to get asked a question about placebo and therapeutic relationship. And so I DM'd and said, hey, I just read your article. Can I say this about placebo effects? And by the end of that conversation, we were writing the article on rupture and repair for JOST. So we've been working together for about, I'd probably say 2.5 or 3 years now. And yeah, and I think originally Giacomo got interested in the work that I did through my first ever publication with contextual factors. So there's been familiarity in our relationship for quite a while now.
Yeah. It's really nice how we can develop interconnection between research and clinician across the world.
Yes. All right. So I'm gonna share my screen, and I'm going to do this. Oopsie, what's happening here? There we go. You're seeing my big screen.
Yeah.
No notes.
You got it. Yep.
Okay. All right. So therapeutic relationship. Two sides to every coin. And that's the title is spawned from, as we've said a few times here, the article in JOST, rupture and repair, two sides of a coin, or both sides of the coin. And so we thought we'd set the stage with a bit of a presentation, just so we're thinking, using the same language, and just to kind of prime the pump a little bit for discussion. So we'll go over contextual factors and contextual effects, the therapeutic relationship, what is it, relational ruptures and repair, and opportunities for personal and professional growth from rupture and repair. Common stories, I think, that we've all heard or felt or experienced in the clinic. When things are going well, and then sometimes we have little blips or major events within the relationships that we have with our patients. Patient comes in upset because their pain has increased, and they are attributing that increase in pain to the last treatment session and specifically the exercise that you gave them. We might become frustrated because we perceive that the patient isn't committed or isn't adhering to a treatment plan. Or sometimes it can be really subtle. We might notice that the patient becomes distant or fidgety when maybe, if we notice why, that maybe we don't acknowledge them in some sort of way, like an important disclosure, for example. So those are common stories. And I think that, as we'll, talk about in the presentation a bit, but certainly maybe in the discussion as well, that we as physical therapists don't necessarily attend to those scenarios very well. We might even avoid those scenarios. And Giacomo and I are suggesting that for the therapeutic relationship, we need to pay attention to that side of the coin, not only the person-centered, developing the strong relationship part of the coin, but the part of the coin that is the tensions, the blips, the ruptures to relationship. Giacomo, I'm going to hand it over to you.
Thank you, Maxi. I totally agree, because as you know, in the clinical practice, how many times it happens that the patient sometimes did not improve when we use this specific or an evidence-based guideline, but we fail with this patient, and the patient sometimes decide to drop off from our therapeutic encounter. So when I was in the clinic, many times I was asking myself, why does the patient decide to stay with me or go away? It is not only a matter of what we do, the specificity of our treatment, but it is, we should also embrace the complexity composed by the context. What is the context? It is very similar. It is an unavoidable component of the treatment that is always presented in every therapeutic relationship, in every therapeutic treatment, administration, and encounters with our patients. So imagine the administration of a therapeutic exercises or a manual therapy technique. When we administer this type of treatment, we well know the specific component of this treatment that is well sustained by different evidence, such as the biological and the neurophysiological mechanisms behind these techniques. But we should also be aware that the other side of the coin, also for the therapeutic outcomes, named as the contextual factor, the contextual component of the treatment, works very well, and it is always presented. We cannot erase it, and we should be aware about that in order to stimulate and help the patient, because the specific component of the treatment with the contextual ones interact each other and are capable to trigger and to enhance the therapeutic outcomes. In particular, among the different therapeutic outcomes, the subjective ones, such as the disability, the pain, and the satisfaction, are really well influenced by this contextual component of the treatment. So again, we need to be aware that it's not only a matter of what we do, the specificity of our treatment, but also the context has a great value. And within the context, we can be aware that there are different dimensions that we should be able to manage. Despite the different authors across the world has tried to identify the dimension that define the context, with my colleagues Marco Testa a few years ago, we have defined this dimension as a contextual factor, identifying them in 5 dimensions. So the context is composed by the overall atmosphere around the therapy that we can explain and introduce in 5 dimensions. We have the clinician that possess specific professional experience, reputation, appearance, beliefs, and behavior. From the other side, we have the patient that arrive to our clinic with specific expectation, preferences, and also with a baggage of previous positive or negative experiences as well. And when the patient and the clinician interact with each other, we have the treatment administration, of course, with that is not only a matter related to the specificity of what we do, the manual techniques instead of the therapeutic exercises, but with the treatment, we consider all the rituality that accompany the therapeutic administration within an healthcare setting composed by different scenarios. The architecture, the environment, such as the lights, the garden, the different facilitator and distractors that we can have within the clinic. But we should be aware that the protagonist of the contextual factor is the therapeutic relationship that clinician establish with the patient, that nurture the encounter and create a very good therapeutic situation capable to modulate in a positive and or in a negative way the therapeutic outcome itself. So we have 5 dimensions, but among them, the most relevant, the most important is the patient-clinician relationship in terms of verbal and non-verbal communication. So, as I told you before, the context represents the overall atmosphere around the therapy. And in this image, you can have a typical example of what the context is. Again, it is not a matter of the specificity of what we do, a manual techniques, a physical agents administration, or a well-known therapeutic exercises, the treatment. It is not only a matter of this element, but the overall atmosphere where the different contextual factors interact with each other can modulate the therapeutic outcome. Indeed, when we are able to offer a positive context and where the different contextual factors are offered in a conscious and a positive way, we are able to stimulate and trigger placebo effects that are the effects of the positive psychosocial context around the therapy. Instead, when we are not aware or we miss the opportunity to think about also the context around the therapy, not only the treatment itself, there is a great risk to deliver a negative context where the different contextual factors are not presented in a very good way, in a conscious way, with a great risk to stimulate nocebo negative effects that are the negative psychosocial context, the negative effects of the psychosocial context around the therapy. And again, I want to remind you the importance among the different dimensions of the context of the patient-physiotherapy relationship. So if we think about the different dimension of the context in terms of both positive opportunity or negative opportunities, we can understand why, with a friend of mine, Maxi Miciak, many years ago, we started to think about how we can develop, how we can talk about the other side of the coin, often not well known and not well managed by the physical therapists in the clinical practice. It is important to understand one thing, that the context around the therapy is capable to create an impact on the patient's brain. The effects of the context are real and can modulate and modify the neurotransmitters presented in the patient's central nervous systems. What I mean is that when we are able to deliver the positive therapeutic encounter with the positive, for instance, therapeutic relationship within the brain of the patient, there are a release of an involvement of the opioid system, of the endocannabinoids, of the dopamine, and also of the oxytocin and vasopressin. Instead, when, for example, the therapeutic relationship between the patient and the clinician is not good, there is a negative context that triggers nocebo effects, there is a strong involvement of the cholecystokinin, a reduction of activation of the dopamine and the opioids, and also an engagement of the cyclooxygenase and prostaglandins pathways. But at the end of the story, what we observe from a clinical practice is that the patient can have, in a positive context, for instance, a reduction of the therapeutic outcome in the reduction of pain in terms of therapeutic outcomes. From the other side, we have a worsening of the therapeutic outcomes. And as I told you before, among the different therapeutic outcomes, the most influenced by the context are the subjective dimension of them, in terms of the illness instead of the disease. And as you can see in this image, different patient-reported outcomes such as pain, disability, satisfaction, and perception of the experience are strongly modulated by the dimension of the context and also by the therapeutic encounter as well. And we know well from a clinical experience every day how important these patient-reported outcomes are from the perception of the patients in terms of effects of the overall therapeutic treatment that we are able to deliver to our patient as well. So we should be aware that the context has a strongly ability to impact the overall therapeutic outcomes. This is only an example obtained by a systematic review with meta-analysis performed in osteoarthritis patients with musculoskeletal pain that inform us that the overall therapeutic outcomes is really influenced by the context. In particular, for pain, we have 75% of the effects, for the stiffness, the 83%, and for function, the 71% of the overall therapeutic impact for the outcome. So we need to be aware that the context matters. So if the context matters, we should be aware and be able to modulate it for the benefit of the patients. So, can you hear me again? Yes. So this is really important because the context helps us to strongly modulate the overall therapeutic outcomes and offer us the opportunity to think again about the psychosocial dimension of the therapeutic encounter. And starting from this side, we can move forward in our communication, in our discussion today, also introducing a different other dimension, or the bad side of the coin, the dark side of the coin of the therapeutic relationship, named as a rupture of them.
All right. Wow. That was like a contextual factors and effects 101 in 10 minutes. And I think it's a really fantastic introduction and really stating the relevance of the importance of contextual factors and what we're speaking about today, the therapeutic relationship. So I think it's important to recognize that the therapeutic relationship is mutual. It is the shared affective affinity between the provider, the therapist, and the patient, and that it is formed by establishing personal and professional connections within a safe environment. And certainly for physical therapy, what I found in my research is that the body is a key aspect of how we attend to the patient and attend to and with the patient regarding their body is central to establishing therapeutic relationships. So you can see here within this model of the therapeutic relationship, we have these components, the conditions of engagement that set up a safe container, safe environment for both patient and therapist to engage, establishing ways of establishing connections with patients, and the therapeutic bond, right? But I mean, it's easy to put up a slide that says, these are the components of the therapeutic relationship. Wow, that looks pretty simple, right? But in reality, relating is very complex. It's an emergent, self-organizing process. And as Giacomo has illustrated quite eloquently, there are biological consequences to relating with other human beings. And so when we're developing therapeutic relationships, there are no algorithms, right? There is no ticky box list of things to do. We have to be able to be present and receptive and respond and be responsive within a clinical interaction. And because of that complexity, because we are humans bumping up against humans, as Giacomo said, we have a therapist coming in with particular characteristics, maybe a mood, a state, maybe you're rushing into the clinic, maybe you were in an accident or you got some news from your partner about one of your kids and you come in and you're stressed. You have your therapist coming in with what they bring into the interaction, but you also have patients that are coming in varying degrees of states of vulnerability surrounding their particular situations, socially, physically, biologically, and psychologically. And so when you have people coming together like that, it's inevitable that sometimes we're going to have tension. Sometimes there may be ruptures. And so ruptures to the relationship are those tensions or breakdowns. And as it says on the slide, they indicate rifts in the way that we're relating with one another. And they're often caused by misunderstandings, moments of empathic discord, or different patterns in relationships that we have. And they can be caused verbally and non-verbally. But I think a key component, as we'll say this over and over again, I think, is that ruptures are inevitable. All right, Giacomo and I both propose that there is no zero tension state in a therapeutic relationship or any kind of relationship. A therapeutic relationship is a type of relationship with a particular mandate, but we have relationships, we're social beings. And so ruptures or tensions are going to show up in any kind of relationship that we have, and we should expect them. And we're going to propose embrace them to some degree. So from the psychotherapy literature, they've categorized ruptures in two ways, right? You'll have the quality of the withdrawal when you have a tension. So a withdrawal means that either you or the patient, the therapist or the patient, is pulling away. There's reduced engagement in the interaction or in the rehabilitation process. The opposite to that is confrontation. So there's frustration, anger, dissatisfaction that could be very tangible, or sometimes they're very subtle. And this can range from minor sorts of withdrawals and confrontations to major breaches. And in our paper in Jost, looking at both sides of the coin, we've identified that we've used psychotherapy theory again to speak about different points or parts of the therapeutic relationship where ruptures can occur. And so ruptures can occur when we have a disagreement on what we're hoping to achieve with the patient in the rehabilitation goals, how we're going to achieve it in terms of what we're going to do, but also empathic failures within the bond. So for example, in this particular illustration here, the patient comes in and provides a major disclosure of something personal in their life. The therapist doesn't really know how to deal with it and just sort of starts talking about something else. And so that can be off-putting, you can imagine, to the patient and have them withdraw likely from the engagement or from the interaction. So these are places where you can look for ruptures. We've also illustrated that there are different levels of tension and risk of rupture. So if we're aware, if we're attentive as therapists, if we're present and we're receptive, and we're picking up on the fact that there's some tension, we can respond in a way that's appropriate, verbally and non-verbally. Level of tension remains low, risk of rupture remains low. But as I said before, we're complex. We're complex human beings. And so sometimes we might recognize that there's something going on, but we're just not quite on spot with how we respond. So we might still continue to respond in a frustrated way, or maybe we're still somewhat withdrawn. So there's a little bit more tension there and the risk of rupture is a little bit higher. And then there's the case where we're oblivious to what's going on in the clinical interaction, or maybe we're not, and we choose not to respond in an appropriate way, and verbally or non-verbally. And so risk of rupture, risk of tension is high and risk of rupture is higher. So, I mean, these are, as I said, relationship is complex. I've outlined three sorts of categories of tension and rupture. So obviously these are fluid, but I think the important thing to recognize is that we're in different states of being, and our ability to acknowledge or be aware that something's happening, tension is happening, and then our ability to respond to that tension, should we acknowledge it, should we notice that it's happening. There's an interplay between those things. So when we're talking about repairing ruptures, Giacomo and I had thought that, and really these came up through our very iteratively and inductively through our discussions in writing the paper, as well as the literature, more the psychotherapy literature, to be quite honest, because we don't have a lot of research in this area in physical therapy. But when we were thinking through how do we as physical therapists address rupture, first of all, we thought it was important that we adjusted our mindset towards ruptures. So if we're going to see ruptures as negative, we might withdraw from that or be confrontational in terms of addressing ruptures, or not want to notice them at all. And so from our perspective, ruptures provide information about, or they're indicators of really important clinical moments, right? And they're naturally occurring, they're inevitable. So we can't and shouldn't avoid them. And that if we actually shift our mindset towards ruptures and kind of pull them in to the interaction, it can actually provide opportunities to strengthen the relationship, and to enable awareness, element 2, and take action. So really, I mean, these are, the slides are up. I'm sure you can read the different points under each one of those, but we need to adjust our mindset, become aware of ruptures and acknowledge them, and then take action to repair rupture. Now, with this last one here, and I didn't put it down, but I think that we also need to be aware that there's addressing rupture in the moment, but you can also come back and address rupture the next session, right? So you may reflect a bit on the previous session when, that didn't go so well. I think I'm going to need to address this with the patient when they come in next time. So there's also that opportunity as well. All right, Giacomo, you want to bring it home?
Yes, of course. Thanks, Maxi. I think that with Maxi, we have tried to finish our point of view published on JOSP with a positive message for the clinicians and researchers as well. Because despite rupture seems to be the other side of the coin, the negative side of the coin, it offers us the opportunity for a growing situation, because at different levels, of course. As a physical therapist, for instance, we can grow both at the professional and the personal level, because we can be aware that other dimensions presented in the clinical encounter can modulate the overall therapeutic outcomes. It offers us the possibility to become aware of the different emotional triggers and reaction produced during the therapeutic encounter as well. For instance, if we are not able to be engaged with the patient, we don't dedicate the good amount of time, we are not aware about the verbal and non-verbal elements of communication with our patient, we can trigger some emotional responses that can open the door for a negative therapeutic outcomes, a dropout, or a negative reaction of our patient that Maxi has presented in terms of withdrawal and confrontation. moreover, we can have the possibility to increase our tolerance for the tensional dimension of the therapeutic encounter and the relationships, because we can. It is a sort of train. We can improve a little bit about the management of this unavoidable component of the human being always presented in our clinical practice, and also can offer us the possibility to become more confident about our power to address, to manage this conflict with the aim to change rupture in a repair situation. Thus, at the end, we can experience that we are vulnerable, and we can have a difficult situation with our patient. But starting from this difficult situation, we can move a step forward in order to become more aware, and after become more aware, can decide and how to act with our patient at the end for the benefit of the patient, and with the aim to increase the therapeutic outcome as well. But also the patient has the possibility to grow, because if we are able to manage to understand their cues, positive or negative ones, and if we are able to manage them, we can repair this negative situation, helping them and giving them the possibility to understand that as a clinician we are present. We are able to meet their cognitive and emotional needs. And through this, we can validate also their negative emotional situation, their negative elements that the patient present us. So what I want to say, taken from a clinical practice as well, is that when we encounter a rupture situation, when there is a possible breakdown of the emotional therapeutic relationship, we should be aware. We can identify the different cues, and starting from this, we can try to modify it with the aim to modify the rupture to the repair situation. Because rupture, of course, is the other side of the coin. But it is an opportunity, because if we know that it exists, we can manage. We can, when we encounter it, we can try to modify with the benefit for the benefit of our patients, and at the end we can strengthen the therapeutic relationship. So, if we have a rupture, there is not it is not a black or white situation. We have a lot of gray tonalities, and we should be able to manage the therapeutic encounter with the aim to repair this negative situation as well. And at the end, we can grow as a providers, and also as a physical therapist, and also as a person at the personal level. And also our patient can improve in the awareness of this. So I think that within the POV, we have provided different examples that arrive directly for our clinical practice as a clinician, where we have had to manage different negative situations. We have tried to identify and tell a story that arrived directly from the clinical practice.
Thank you, Maxi and Giacomo, for that excellent presentation. One of the things I really enjoyed about both the article and your presentation is just the nuance and the attention just to the positive and negative sides of this therapeutic relationship, and how that's paired with growth. And I think one of the questions, kind of diving into that nuance, is something I think that you're getting at, is that as physical therapists, especially in the area of pain, our job is to see a future, or see an outcome that our patients may struggle with. And part of that is asking things of our patients that may be scary and fearful, and they may have a variety of emotional responses to. And I think, so as thinking about this is, it really becomes salient with our students when I'm teaching them about pain, and that most of our students, when they first start learning, want to do interventions that don't make they don't want the worst thing that could happen is if a patient's pain got worse, by something that we did. And that because of the what you described might be that rupture in the relationship, a disagreement on perhaps a task, and which would be the task would be to alleviate, from the patient's perspective, to alleviate their pain. So I'm really interested in kind of thinking about like this idea, but also how these different components can almost vary in different ways throughout the course of the rehabilitation, how, and just to get your thoughts, how they might build off of one another, and that how avoiding just the act of the rupture can impede the progress of the rehabilitation. That's a lot. I just unloaded on you, you both. So, but it was like where my headspace was at as you guys were presenting, and we can tackle a small part of that.
You've been waiting. You've been like, oh, this is brewing. And I told you it could go very stream of consciousness, this whole session, right? Okay, so let me see if I'm understanding where you're at. So are you talking about like sort of fluctuations in the therapeutic relationship, and maybe where there's tensions, when there's not, when things are going well, or sort of how things can progress?
Well, I think I'm talking about two things as you ask that question. I think one part is just avoiding tension in the relationship can impede the progress of the rehabilitation, right? If we're seeking comfort in that relationship, we can avoid the gains that some of our patients need to make, and engaging with our patients in a way where there might be a little bit of tension.
Well, and I think you said it. There's certain situations where we might anticipate there being tension, like if you have to bring something up that's going to, it's going to be a more challenging conversation, or your experience has told you, and Giacomo could probably speak to this more, as he's right in the thick of clinical practice at the moment. But I think I repeat this very, very often, is that we have to return to, I think, principles of practice and setting up a safe container. So I told you I always have appendix slides, so I'm just going to share my screen again.
I totally agree, Maxi.
So I just flipped to this slide. Hold on here. This side, be the ground. All right. So I think as therapists, we need to recognize that we're the ground of the relationship, right? And so when we enter into any interaction, we need to be setting up that safe container, right? And so we need to be present and receptive, because that sets us up to be able to not only notice or recognize whether there are ruptures in the relationship or not, or what's happening within the relationship and how to respond to them, but neurophysiologically, we are grounded. So when we set up a safe container, we set up a situation where physiologically we're helping everybody regulate so that we can engage, as therapists, we're grounded, but also patients pick up on that, right? Neurophysiologically, neuroceptively, they pick up on whether it's a safe environment or not. And their nervous system regulates. And then we can actually have discussions about difficult topics, right? So I think that that when we want to embrace tension, if we know that we can ground ourselves by preparing to come into clinical interactions, but also having ways of regulating ourselves when tension comes up, that we are going to be better able to meet that tension with the patient versus plowing through it or withdrawing from it. And Giacomo's nodding, so I'm just going to let him take the floor.
Yes, I think that you have a great reason, because we see this situation every day in our clinical practice. I think that we should also be more emotional intelligent, if you want to use technical terms. What I mean is that we should be more aware about our status in terms of emotional status, interactional status, and also keep the eyes towards the patients all the time. So within our clinical reasoning, of course, we should follow the evidence, try to assess the pain intensity, the neurophysiological mechanisms behind the clinical presentation of our patient with the aim to guide what we do, the specificity of the treatment. But also, we should develop a more aware clinical reasoning based also on the amount of the quality of the therapeutic encounter as well. Because when we observe an increase of the temperature of this emotional encounter between the patient and the clinician, we should be aware to modulate it and reduce it, because there is a great risk that what we do, the technique, for instance, the therapeutic plan, is not perceived in a very good way by our patient, but not because the problem is the technique, but because the therapeutic encounter that we have created, little by little, becomes ruined by something. And one of the most important dimensions is the therapeutic relationship, what we say. And I want to say you another things, also thinking about the clinic. If you ask to our patient how they can be perceived as satisfied with physical therapy treatments, they say us that in musculoskeletal practice, they are satisfied not only if they achieve the total and the overall amount of clinical outcomes, for instance, reduction of pain or improvement of disability in a complete way, but they are satisfied also if they have had the possibility to receive a good contextual dimension. And within them, one of the most important is the therapeutic relationship. So for a very long time, the clinician has put their efforts and their focus on the positive side of the coin. But it is simple. When everything works, it's more simple. But what we can do when the things becomes not good as we want? What we can do? Modify the words, of course, modify the behaviors, the nonverbal communication. And within the POV publishing just with Maxi, Miciak, we have provided in a table different examples about how we can do these things. Because we do it every day in our clinical practice. Because the final goal is to avoid a dropout of the patient within the therapeutic plan. Is to help the patient to achieve the therapeutic goal. But to do this, we should again be aware that it's not only a matter of the technique, but also it is a matter about how we manage the therapeutic encounter. And the therapeutic encounter is something that is fluid. It is not directed and linear. There is also a change, and we should be able to perceive the cues that the patient offers us. Because if we are able to see this, we can arrange and modify our encounter for the benefit of the patient. And I think that the slide that Maxi has posed as a post here really describe what every day can become real within our clinical practice. Different types of ruptures.
So Eric, I think I'm it's sinking in, I think, what you're asking. Because it's like, I think what you're saying is if we avoid that tension, right? If we avoid the tension, we're actually pulling away from our ability to go deeper with better understanding of what the patient's needs are, better understanding of what they want to achieve, better understanding of what we need to be doing, and working collaboratively in this alliance, right? So if we pull away, we actually just stay on the surface of what needs to be done within the clinical interaction versus going, okay, here's a tension. Now we've come together there, and now we've actually got a better understanding of what needs to be done and what we want to do together and collaborate together. And that has actually strengthened the relationship because we have attended to the tension.
Yeah, I think that's exactly it. I'm looking at that slide. Oh, you just pulled it away.
Oh, okay.
Like if we put it back up there and we say, so I'll just make this statement and then maybe we can open this up to other people to ask questions, because I think our guests might have some interesting questions as well. But kind of what I was saying specifically, like you have a patient that comes in that low back pain, wants to have less pain, improve functioning. There's a bond with the patient that's an emotional bond. There's an agreement on goals, those two things, but the task, there might be a disagreement on task. Like the patient in this case may prefer ultrasound, and your professional judgment as the clinician may not agree with that. Now you, I guess, in some ways could use ultrasound as a way to build bond and through agreement on tasks early on, but then there may be a point where if you avoid that conversation about what you think is the best evidence for the patient and how to move them forward, then you're not actually helping the patient move forward because you're avoiding this emotional component to the relationship and the possibility of rupture. Does that, I think that I'm trying to be a little more concrete and less abstract in my explanation. How does that sit?
Yeah, go ahead, Giacomo, go ahead.
I think that it is a really an everyday observation in clinical practice. Sometimes the patient want, for instance, an hands-on technique for a clinical condition and or a physical agents. And as a clinician, we know that the therapeutic exercises works well in accordance with evidence. And in that situation, we can have a rupture situation. But what I think that we can do is to discuss with our patient, explain him or her that what we want to do is for his or her benefits. So I think that it's not only a matter of a disagreement regarding the task, but about how we communicate with the patient this possible differences presented within our therapeutic encounter. Because sometimes the patient we know wants something that does not work, but we are healthcare providers and we should offer to our patient the best evidence. So what is difficult is communicate and help the patient to understand that what we propose would help him. Indeed, it is an opportunity to assess during the physical examination, during the therapeutic administration, and also during the history taking, the patient values, the expectation, the preferences. It is an opportunity to understand this, but this information should guide our clinical decision making. But we are healthcare providers, so we should be aware that we need to work within the ethical boundaries. And when we decide to do it, we should communicate this element to our patient. So I think that one of the most important elements is about how we communicate this possible situation of disagreement. Because if we don't communicate it, we open the door for a very high amount of rupture and for a great nocivo situation.
And just before we go on to hear what other people want to chat about, Giacomo made a very important point. It's not necessarily what we have to say all the time, it's how we are saying it. And so that's where I think if we come into those situations where, you know, you have some evidence and experience, it conflicts with maybe what the patient wants or has heard or has experienced in the past. I had ultrasound in the past, it helped me, right? You know, I think that to be able to come in a grounded way, and as Giacomo said, have the intention of, we're having this conversation because I'm here to try to help you the best way that I can. And so it's the tone that we use, it's the sincerity and being genuine and demonstrating that we're committed to helping and supporting that person that may open them up to other options and being able to engage with you in that way, in the complexity of that situation. Because it's not simple. It may seem black and white, but I don't think it is.
All right, Craig's asking me to stop hogging, so let's turn this over to our guests here and or our attendees and see if we have any questions from them. You can just raise your hand, chime in, put it in the chat. All right, I guess I will ask another. Oh, Nancy raised her hand. Go ahead, Nancy.
Yeah. So it's interesting. Thank you so much for this, great information. And I think I'm primarily a clinician. So when I hear your presentation, I'm like, oh, I used to think I got fired, as a clinician. And now I can just say, oh, it just ruptured. I kind of think I like that better than like thinking that I was fired. But I do pediatrics. So there's a whole nother level when I'm working, because it's not only the therapeutic relationship with the child, but the parent. And where I struggle as a clinician is a lot of times when the parent and the child are not on the same plane. And so I get to a point where I'm like, ooh, okay, the parent is paying for it, but I'm working with the child and I want to know what the child's goal is. But a lot of times the child's goals are not the same as the parent's goals. So, I would love any insight as far as how to navigate, any of those kinds of situations, any nice little clinical pearls or something that you could hand me.
Thank you, Nancy. I think that you have really described well what happens in the pediatric situation. So I think that the management of the therapeutic relationship and also the possible rupture situation are more difficult, because more challenging, because we have not only the patients, the children, for instance, but also their parents. So we need to be aware to work at different levels, because sometimes I think I don't have not too much experience with pediatric rehabilitation, but I think that with your parents, you can work more at the conscious level. Sometimes with the children, you should offer more emotional therapeutic situation. So it is not too much difficult, but more complex. And I think that what we have tried to do, of course, with Maxi, is to offer to the scientific and the clinician community the opportunity to embrace this complexity, to widen the perspective of analysis, inserting within our awareness, our baggage of our third providers, as an opportunity, the power and awareness about the therapeutic relationship. So I think that if we add more people within the therapeutic arena, we need to be more be more engaged with this therapeutic situation.
Yeah, and I'm not a parent, but I'm trying to put myself in a situation or in the shoes of the parent who may be very anxious, have some fear around what's happening with their child, and maybe even a loss of a sense of control of what's happening. And so I think, once again, for me, I always am going to come back to being able to create that safe container where you can acknowledge that, even if maybe they're not saying it or you're not sensing it. It's that, there's some tension there, and just acknowledging that, and that, wow, this must be really scary, or it must be hard to, give up that control, right? And I think that opening that space up and holding that space for the parent may take you to a different level of being able to engage about, or get some agreement on the goals, and negotiating in a way that helps reduce their responses from a place of fear or anxiety. I don't know if that resonates with you at all, Nancy.
It does. Thank you. Yes. You know, and we talk a lot at our clinic or our hospital about, you know, the environment and the feeling safe and safe to, you know, just discuss. And I think that that's a great way of opening up, you know, the relationship of saying, you know, even, is there anything else that you want to discuss? Do you have any other worries? You know, and even just open-ended, let them, you know, at some time during that interaction. I like that. Thank you.
All right, we've got a few minutes left here. I guess one thing, maybe just to leave us with, if you have any quick insights on how, if you could recommend ways for therapists to increase their ability here. I mean, obviously attending something like this is a good step, but where might a PT that listens to this Paincast go next in terms of their own professional development?
Well, my professional journey involved, and I'm not suggesting that people do this, but I actually did a psychotherapy training in a body-centered form of psychotherapy called Giacomo, because I wanted to be better at developing therapeutic relationships. And so that's a pretty big thing to do. It was about 4 years, but I think there are different frames that you can explore. There's compassion focused care, right? You know, motivational interviewing, you know, courses that have, from my perspective, some sort of principles that they are landing in, so that you have principles that you're taking into the interaction that are helping you decipher what's going on. All right. So I really stray away from how-tos, like do this, do this, do this, do this, do this. Trauma-informed care is another one. I would, if anybody dealing with pain or patients like that with chronic pain or chronic conditions, trauma-informed care. I also did training in sensory motor treatment of trauma from a psychological perspective. And that really shaped not only my knowledge of myself, my psychotherapy training, which is huge, but also how I created that safe container. All right. And I think anything that's going to give you a way to help you land in principles and shape the way you interact and interpret what's going on will be helpful.
I agree, Maxi. I want also to add another elements also that integrate the training. When you are at the clinic, keep the feet on the ground and try to think all the time and ask you one question. If I were a patient, what would I want? What would I expect in terms of therapeutic relationship, in terms of therapeutic encounter? This is one of the most important questions that guide my clinical practice. Not only what the patient expects in terms of treatment, but what they desire to receive in terms of explanation of their cognitive and emotional needs, and in terms of therapeutic encounter as well. This is, I think, personally, one of the most important questions that drive my clinical practice every day. And I hope that you can also share this thought with me.
Well, I want to thank you, Giacomo and Maxi, for joining us and helping us American physical therapists out here improve our practice and understand more about the therapeutic relationship. It's gone too fast, as it always does. And I'm recording this lecture. It'll go on our Facebook and we'll send it out that way, so that if you're not able to watch it or have only been able to attend to part of it, you'll have access to it there. But thank you all. And I look forward to seeing more of your work in the future. And
thanks very much.
Thanks a lot. Keep in touch, by the way.
Have a great day. Bye for now.